Every day, thousands of people will undergo some type of surgical procedure. As they do, they entrust their well-being and safety to the operating room team. Even as technology in the surgical setting continues to advance, one thing remains constant. Each and every patient must be correctly positioned for their particular procedure. That's why this video was created, to help you, to show you, and to ensure that every patient that comes into your operating room is correctly positioned. That's our goal, to create a safe environment and improve patient outcomes.
Ensuring a safe and comfortable environment for every surgical patient is the responsibility of the entire operating room team. Working together, the surgeon, surgical assistant, anesthesiologist, perioperative nurses, and the operating room technicians can create the optimum position and thereby improve patient outcomes. Over the next 20 minutes or so, we'll review general guidelines for patient positioning, discuss the importance of the patient interview, show common positioning devices, review the use of padding, demonstrate the 4 basic patient positions, and the pressure points you need to know about. We'll also be discussing some do's and don'ts to prevent patient injury. We have a lot to cover, so let's start with understanding the basic guidelines of patient positioning. The Association of Perioperative Registered Nurses has issued recommended practices for the positioning of patients in the perioperative practice setting. These guidelines indicate that the patient's position should provide the adequate exposure needed by the surgeon for the procedure. IV and monitoring lines should be accessible, and the position should not compromise the patient's circulatory, respiratory, musculoskeletal, neurological, or integumentary structures. The care of this surgical patient begins with the preoperative interview. No one should ever underestimate the importance of this information-gathering step. The interview begins with a thorough chart review. The patient's medical evaluation will reveal any risk factors or medical conditions that may predispose the patient to positioning-related complications. These include diabetes mellitus, peripheral vascular disease, renal failure, pre-existing neuropathies, and obesity. Before you begin the interview, introduce yourself to the patient and explain why you will be asking questions about the patient's condition and medical history. By asking for the patient's active participation, you will receive a more cooperative and compliant response. Approach the interview with a smile, with confidence and professionalism, and you will leave the patient with a positive and upbeat feeling. Here are some of the things you should be looking for: the patient's general level of awareness, age, weight and height, skin condition, nutritional status, current medications, if any, the patient's normal range of motion, and any physical abnormalities or limitations, back problems, neurological problems, previous surgeries, complications with surgery, or if the patient has any implants, such as total joint prostheses. By learning about the patient's medical history and condition, as well as possible risk factors, the OR team can use this information and knowledge to take the necessary precautions and prevent positioning-related injuries. The next step is to develop a plan of care. Review the type of anesthesia to be administered, the surgical procedure, the position required, the surgeon's preferences, the estimated length of the procedure, and the patient's status. Discuss potential problems or concerns with members of the team and formalize the positioning plan in advance. While these things take time, the benefits outweigh the inconvenience. Remember, the patient always comes first. Next, let's take a close look at some of the positioning devices. A variety of devices and accessories are available to the surgical team to aid in achieving the optimum position and provide safety and comfort for the patient. As a member of the team, it is a good idea for you to learn the storage location for these devices and to practice attaching them before they are needed during a case. In addition, all devices should be clean and in good working order. Remember the old saying, practice makes perfect. Positioning devices fall into two general categories: devices that attach to the operating table and those that do not attach to the table. Examples of devices that attach to the table include arm boards, lithotomy stirrups, and lateral positioning bars and posts. Some positioning assist devices that are not directly attached to the table include gel pads and positioners of various sizes made of actin viscoelastic polymer, pillows, egg crate foam, vacuum bean bags, and sandbags. In addition to these assorted devices, the importance of proper padding is being increasingly emphasized. New research studies indicate that as much as 25% of postoperative pressure ulcers may be OR-induced. Capillary closure as a result of pressure and shear is the main cause of breakdown. It is recommended that padding and positioning devices maintain a normal capillary interface pressure of 32 millimeters of mercury or less. We also know that the patient's risk for ulcer formation and other complications increases as the length of the procedure increases. The sustained pressure on tissue, nerves, and vessels can leave the patient with an undesirable postoperative outcome. It is important for you to be aware of bony prominences and anatomical areas that are at greater risk for pressure-related injury. A full-length table pad will offer protection and comfort for the patient. It is also crucial for each member of the surgical team to have a general understanding of how the anesthesia administered during a procedure can place the patient at greater risk for injury. For example, the muscle relaxants typically given with general anesthesia may allow for overstretching of muscles, tendons, and joints. Under general anesthesia, the patient's normal pain and pressure receptors have been blocked, and the patient is unable to inform the team of problems. Nerves and vessels can be stretched or compressed, causing an injury. In addition, cardiovascular changes may include peripheral dilatation, decreased cardiac output, and hypotension. Hypotension, whether induced or spontaneous, reduces tissue perfusion and increases the risk of tissue injury. For all of these reasons, it is easy to see why the anesthetist plays an important role in patient care in the operating room. Some positions may impede air exchange and ventilations or create effects that may be undesirable. Working together, the surgical team can incorporate good patient assessment skills, look at potential physiologic effects, check risk areas, determine the patient's status in advance, and apply physical assessment skills to achieve the most desirable outcome. Next, let's look at the first basic surgical position, the supine position, sometimes referred to as the horizontal supine position. The supine position is the most common surgical position used. The operating room table is flat, and the patient is lying on their back. A padded arm board may be used, which is attached to the table at the same height of the table. The angle of this arm board should be no greater than 90 degrees. Hyperabduction of the arm greater than 90 degrees, or a difference of height, may cause injury to the brachial plexus. Supination of the hand on the arm board will rotate the ulnar nerve into a safer position where there is less chance of the nerve being compressed on the arm board. Be aware of staff that may lean on arm boards and cause a compression injury. For patients whose arms must be out on arm boards for long periods of time, slight flexion of the elbow from a wedge under the forearm can help to reduce the stretching of the nerves in the upper extremity. Always check to be sure that the arm boards are well padded. If the arms are to be placed at the patient's sides, the palms should rest against the thighs. When a draw sheet is used to secure the patient's arms at the sides, it is important to tuck the sheet between the patient and the mattress, and not between the mattress and the operating tabletop. This decreases the risk of the arms sagging over the sides of the operating table and causing compression of the ulnar nerve or radial nerve. Note that the correct placement of the safety belt is about 2 inches above the knees. Be sure the belt is not too tight as to put undue pressure on the legs. The anesthesiologist is responsible for maintaining the patient's head in alignment. A proper head support will prevent stretching of the neck muscles and maintain the head in a neutral position. A variation of the traditional supine position is the contoured supine position, sometimes known as the lawn chair position. In this position, the hips and knees are flexed slightly, putting the joints in a more neutral position. This helps to relax the lumbar spine and create a more comfortable position for the legs. Patients that are required to lie awake or are sedated and required to be immobile for long periods of time will favor the contoured supine position. Pressure points to be aware of when a patient is in the supine or the contoured supine position include the spinous processes of the thoracic vertebrae, the scapula, olecranon, sacrum, coccyx, calves, and calcaneus. Keep in mind that these areas will receive more pressure than usual and require proper padding when positioning a patient. Always check these pressure points to prevent possible injury. The next basic surgical position we will review is the lithotomy position. To move a patient into the lithotomy position, start with the patient in the supine position flat on their back, and move the patient down so the patient's buttocks lies at the edge of the lower table break. Be sure to provide adequate padding to the sacrum, as pressure to this area will increase when the legs are elevated. When possible, the arms should be placed on padded arm boards at an angle of 90 degrees or less. Placing the arms at the patient's sides in the lithotomy position puts the patient at risk for a pinching or crushing injury of the fingers when the lower table section is re-elevated. There are many types of supports available to secure the lower extremities in place. Follow the manufacturer's recommendations regarding the proper use of these devices. After selecting the support device to be used, be sure that they are in working order and secure them tightly to the OR table. Both legs should be elevated simultaneously and placed in these support devices. Varying degrees of elevation may be required depending on the type of procedure being performed and the access needed. Gynecological, urological, and some general surgery procedures will utilize the lithotomy position. Do you know why both legs should be raised and supported simultaneously? Here are some of the reasons. First, this technique will help to avoid dislocation at the hip joint. Second, it minimizes the risk of dropping or injuring one extremity while the other is being manipulated. Third, elevating both legs simultaneously helps avoid rotational stress on the lumbar spine, which may cause postoperative pain. And last, the procedure maintains the limbs in a symmetrical arrangement. When using candy cane or lollipop-type stirrups, care must be taken to avoid compression of the peroneal nerve on the outer aspect of the leg just below the knee. Adjust the stirrups to avoid compression and always use padding as an extra safety measure. During the procedure, be aware of staff pushing out on the legs to gain access to the operative area. At the conclusion of the procedure, both elevated extremities will be removed from their supports, knees brought together, lowered slowly and simultaneously. This will help to prevent torsion to the relaxed spine and allow for the vessels in the lower extremities to refill slowly, minimizing the appearance of a hypotensive episode due to hypovolemia. Pressure points to be aware of when a patient is in the lithotomy position include the occiput, the spinous processes of the thoracic vertebrae, medial and lateral epicondyles, olecranon processes, scapula, sacrum, femoral epicondyles, medial and lateral malleolus, and calcaneus. Now let's look at the lateral decubitus position, usually just called the lateral position. As you know, lateral means to the side, and decubitus, a Latin word, means lying down. When describing the lateral position, it always reflects the side of the patient that will rest against the surface of the OR table. So, for example, a patient in the left lateral decubitus position will be positioned with the left side down, allowing access to the right side of the patient. A minimum of 4 people is needed to move the patient into the lateral position. Attention to proper body mechanics will reduce the risk of injury to the patient and to the staff. The anesthetist is responsible for moving the head, 1 person at the feet and 1 on each side of the patient. After anesthesia is administered, the patient is turned from supine to one side. This is accomplished with a rolling action, and the downside arm is extended on an arm board. An axillary support, commonly called an axillary roll, is used to free the downside shoulder from the direct lateral pressure produced by the position and relieves the pressure on the axillary artery and nerve. Proper placement of the axillary roll should be just inferior to the axilla, supporting the area of the upper rib cage. An improperly placed roll into the axilla can result in a vascular obstruction of the downside arm. A check of the radial pulse or use of pulse oximetry on the downside arm after the axillary roll is in place will confirm adequate perfusion to the limb. The upper arm may be supported by pillows, a lateral arm support, or on a well-padded Mayo stand. The rule of bees applies to the lower extremities. The bottom leg gets bent. That is, the downside leg will be flexed. Be sure to provide adequate padding between the legs. To maintain the patient in this position, sandbags can be placed front and rear, or vacuum-style beanbags can be used. Wide tape should be applied across the patient's thighs and secured directly onto the OR table. Head support is extremely important. Be sure that the height of the head support is enough to allow the head to be in a neutral position. Improper height can cause stretching of the neck, which may result in a cervical injury. Pressure points to be aware of when a patient is in the lateral position include the ear, acromion process, olecranon, the ribs, iliac crest, greater trochanter, medial and lateral condyles, and the medial and lateral malleolus. In addition to ensuring adequate padding, it is important to assess these pressure points pre- and post-op. The next and last position to review is the prone position. In the prone position, the patient is lying face down on the operating table. Before attempting to move the patient from a stretcher to the prone position, an adequate number of personnel are required to accomplish this maneuver safely. Of course, staff should use proper body mechanics to avoid injury to the patient or themselves. Also, before moving the patient, anti-embolic or sequential compression stockings are recommended and should be applied. There are a variety of devices and products available designed to maintain a patient in the prone position. Depending on the type of surgery, the primary goal of supportive devices is the same: to relieve the pressure on the abdominal viscera, which can restrict movement of the diaphragm and make ventilation difficult, or possibly impede venous return through the inferior vena cava. Select the required support devices to be used in advance and set up the operative table to receive the patient. Check the heights of the OR table and the stretcher and adjust them so they are at equal heights and safely locked in position. Be aware of all lines and tubes before moving the patient and place the patient's arms at their sides before the turn. Also, be sure that the arm that will be the downside arm is secured. This will avoid the risk of a pinching injury between the stretcher and the operating table or a possible shoulder dislocation. To move a patient into the prone position, a log roll maneuver is incorporated. The starting point is usually the patient in the supine position on a stretcher or a bed. The anesthetist will coordinate the move and be responsible for the patient's head. Turners will turn the patient from the stretcher side, and receivers will receive the patient on outstretched arms from the opposite side of the operating table. One additional assistant will be at the patient's feet. Once the patient has been successfully turned, the head will be straight in a head support device or turned gently laterally. The arms can remain at the sides or placed on padded arm boards. When lateral chest rolls are used to support the patient, the roll should provide support from the acromioclavicular joint to the iliac crest. Be careful that the chest roll does not extend beyond the iliac crest. This could compress the femoral nerve and artery. Here are a few things to keep in mind. Females with large breasts should be placed laterally. Male genitalia should hang freely with no compression. Provide adequate padding. This includes padding under the knees and use of a support under the ankles to prevent plantar flexion. Remember to maintain the foot in dorsiflexion. When pronating a patient directly on the OR table, it is important to lift, not pull. Lifting will avoid shearing, which can result in tissue injury. If any procedure requires a repositioning of the patient, be sure to reassess the patient after the new position has been achieved. Pressure points to be aware of and to protect with adequate padding when a patient is in the prone position include the ears, eyes, cheeks, acromion process, breasts, anterior iliac spine, male genitalia, patella, and the patient's toes. Now that we've reviewed the 4 basic patient positions, let's look at the importance of postoperative assessment and documentation. The post-op assessment begins immediately in the OR as the patient is undraped. Look for anything unusual. Check the patient's skin for reddened areas, which could be a sign of tissue injury. Carefully check those areas that were receiving direct pressure as a result of the position. Document all findings in the nurse's notes and advise staff in the post-anesthesia care unit of any unusual findings or interoperative circumstances. Staff should follow established hospital policies and procedures for documenting patient care. It is crucial to note the patient's position, devices used to achieve and maintain position, padding materials, and areas of concern.
Proper and safe positioning of the patient for surgery requires teamwork. Remember that each time a patient enters the operating room, our goal is to create a safe environment, prevent injury, and improve patient outcomes. So learn good interviewing techniques and incorporate them into your preoperative assessment. Spend some time learning about available support and positioning devices. Complete the preoperative planning steps and use your knowledge and experience to create a safe and comfortable position for every patient.